You use them every single waking moment, really processing light, color, depth, all this information with just incredible speed and precision. Your eyes, they're such an intricate, vital system.
Absolutely amazing when you think about it.
But how do the experts, the ones who actually care for our vision, how do they evaluate this complex organ? How do they perform a clinical examination that, goes way beyond just reading a chart?
Well, it's really about a systematic approach, very detailed, using a whole range of tools and techniques to look inside, assess function, and figure out what's going on beneath the surface. It's quite an art form, actually, a diagnostic one.
Right. And for you, the listener, especially if you're aiming to really master this understanding, this deep dive is your guide. We're going step by step through the detailed clinical examination of the eye. We'll unpack the techniques, the principles, all the crucial insights professionals rely on.
Yeah, and our guide here is a pretty comprehensive text on ophthalmic examination.
Exactly. And our mission is to cover everything presented in that material, build a foundational understanding so deep that you feel genuinely well informed, almost like you've mastered the subject yourself.
And that mastery starts with understanding how the eye actually functions, doesn't it? Assessing visual perception.
Yeah, things like form sense, field of vision.
Yeah. How the eye handles the different light levels, color sense too. And it's absolutely vital, remember, to test each eye separately for most of these assessments.
Definitely. And the most fundamental measure, the one everyone thinks of first, is visual acuity.
Right. Visual acuity, or VA, it's simply the eye's ability to resolve fine detail,
Yep.
to discriminate between two separate points.
Okay.
Think about the fovea, right? Packed with cones, about 2 microns apart.
Yeah.
Now, to resolve 2 points distinctly, your brain needs input from at least one unstimulated cone sitting between 2 stimulated ones.
Ah, I see. That separation is key.
Precisely. And that tiny 2-micron separation corresponds to a visual angle of roughly 25 seconds of arc. Very small.
And this basic principle that's behind the familiar Snellen charts we see everywhere.
Exactly that. Snellen charts use letters, or optotypes, designed so that the critical detail, like the width of the lines making up the letter, or the gap in a C or an E, that detail subtends 1 minute of arc at a specific distance.
1 minute of arc for the detail.
And the whole letter itself subtends 5 minutes of arc at that same distance. So as you go down the chart, the letters get smaller, right? They're designed so the detail subtends 1 minute and the whole letter 5 minutes, but at progressively shorter distances.
So that big E at the top, that's designed for 60 meters. 5 minutes of arc total at 60 meters.
Correct. And the bottom line, the 66 line, that one subtends 5 minutes at 6 meters. And that's why testing is typically done at that fixed distance of 6 meters, or 20 feet in the U.S. system.
Why that specific distance?
Well, at 6 meters, the light rays coming from the chart are considered essentially parallel. So it minimizes the need for the patient to actively focus or accommodate.
Ah, okay. Takes accommodation out of the equation mostly.
Yeah. Which leads straight to the Snellen notation. V equals patient distance divided by the distance a normal vision person sees it.
So 66 is normal.
Yeah.
What you see at 6 meters, a standard eye sees at 6 meters.
Exactly. And if you can only see at 6 meters what a normal eye sees way back at 18 meters, that's 618 vision.
Or 20/20 and 20/60 in the U.S. Okay.
Precisely. Now, what if vision is really poor? They can't even see the top letter at 6 meters.
Right. What then?
You walk them closer. If they can see it at, say, 3 meters, you record V equals 360.
Okay.
If they still can't see the chart, you move to counting fingers. Maybe V equals CF at 1 meter, then hand movements, HM.
So it's a progressive scale downwards.
Absolutely. If they can't see movement, you test for perception of light, PL, in a totally dark room. Shine a bright light. Can they see it? Yes or no?
And you can even ask about direction.
Yeah, can they tell which direction the light is coming from? That's projection of light, accurate or inaccurate in different quadrants. And if there's just nothing, no perception of light at all, it's V equals no PL. That's a crucial way to grade very profound vision loss systematically.
That covers the classic Snellen method really well. But you mentioned there's a more modern, scientifically driven way, MAR and LogMAR.
Yes, exactly. Especially important for research, clinical trials, or when you need to track really subtle changes in vision over time. MR stands for minimum angle of resolution.
Okay, MR.
It's basically the visual angle of the smallest detail seen expressed in minutes of arc. You calculate it by taking the denominator of the Snellen fraction and dividing by the testing distance.
So for 612 vision, that's 12 divided by 6.
Right, which gives you 2 minutes of arc MAR. For 66, it's 6 divided by 6, which is 1 minute of arc MAR. Simple inversion.
And LogMAR is just the logarithm of that MR value.
Correct, base 10 logarithm. The real advantage of log-Mer is that it provides a linear scale for visual acuity loss. Snellen steps aren't equal, but log-Mer steps are.
Ah, so each line down the chart is an equal step in visual loss?
Pretty much, yeah. Charts designed for log-Mer, like the Bailey-Lovie or the ETDRS charts, have this constant geometric progression in letter size. Each line is typically a 0.1 log-Mer step, and even better, each letter on a line is usually worth 0.02 log units.
That sounds much more precise for tracking.
It is. Plus, these charts have the same number of letters on each line, and the spacing between letters and rows is standardized relative to the letter size. That consistency is why log-Mer is the gold standard in clinical trials and research.
So Snellen is good for a quick clinical check, maybe screening, but if you need real precision or tracking change.
Log-Mer is the way to go, definitely. And whichever chart you're using, illumination is absolutely critical.
Right, the lighting must make a difference.
Huge difference. Acuity improves significantly as light increases, although the effect levels off at very high brightness. The standard is never below 20-foot candles, and ideally around 100-foot candles is used. Consistency is paramount for reliable results.
Makes sense. And so after checking the vision, the next logical step is figuring out why it might not be normal, right? And the pinhole test is a quick way to check for refractive error.
It is, yeah. Very simple, very useful. If the visual acuity improves when the patient looks through a pinhole, like a small hole in an occluder,
Okay.
it strongly suggests that the blurring is mainly due to a refractive error. Needing glasses myopia, hyperopia, astigmatism.
How does that work? Does it just block out stray light?
It effectively increases the depth of focus, kind of like stopping down the aperture on a camera. It limits the light entering the eye to the central rays, minimizing the blurring effect of refractive errors in the periphery of the cornea or lens.
Got it. So if pinhole helps, it's likely refractive. Then you do a full refraction to find the exact prescription.
Exactly. And after you've determined the correct lens power through refraction, you measure the best corrected visual acuity, or BCVA. That's the best vision the person can achieve with their glasses or contact lenses.
So you might record something like V equals 618, improving to 66 with a plus 1.00 lens.
Perfect example. Their BCVA is 66 with that correction.
And that's all mostly focused on distant vision. Near vision, like for reading, is tested differently.
Yes, it is. Near vision is usually assessed at a standard reading distance, commonly 40 centimeters. The charts use different notations, like J notations from Jaeger, or N notations which relate to Times New Roman font sizes.
Are those as standardized as Snellen?
Not really, unfortunately. There's less standardization, which is a bit of a drawback. Sometimes they use numbers or Landolt-Cs too, but reading involves a larger area of the retina than just pinpoint central vision. It uses the fovea and the curvaveal areas, so it tests a slightly broader function.
Right, makes sense. Now, what about situations where standard testing just isn't possible? Like someone with a really dense cataract or very young children who can't read letters?
Yeah, those are definite challenges. And this is where clinical skill and specialized tools become essential. For dense cataracts, where you just can't see the retina.
You can't use a chart, obviously.
Right, so you might use something like a laser interferometer or a potential acuity meter, PAM.
How on earth do those work through an opaque lens?
It's pretty clever, actually. The laser interferometer shines coherent laser light through the cataract. It creates a diffraction pattern directly on the retina, like a set of fine parallel lines.
Okay.
The patient just has to report the orientation of these lines. Because the pattern formation relies on diffraction, it's less affected by the cataract's opacity than, say, trying to form a clear image of a letter. So you can estimate the retina's potential acuity post-surgery based on the finest lines they can resolve.
Wow. And the potential acuity meter?
The PAM works slightly differently. If there's maybe a small, clear window in the cataract, it projects a tiny Snellen chart onto that specific spot of the retina, bypassing the worst of the opacity. Again, giving you an idea of the potential vision after surgery.
That's ingenious. Predicting vision through the blockage. What about preverbal children? Infants?
Oh, that's very challenging. Distraction, they can't cooperate, can't read. For infants under 2, the main techniques are pattern visual evoked potentials, VEPs.
Measuring brain waves.
Essentially, yes. Measuring the brain's electrical response to seeing visual patterns. Or you use preferential looking behavior. VEP generally tends to correlate better with standard acuity tests like Snellen or E-tests once the child gets older.
And preferential looking. What's the principle there?
It relies on the simple observation that infants naturally prefer looking at something patterned over something plain or uniform.
Ah, like the Teller acuity test uses.
Exactly. The Teller test uses a series of cards. One half has black and white stripes or gratings of varying fineness, and the other half is just uniform gray. An examiner watches the infant's eyes through a little peephole in the card and judges which side the infant looks at more often.
And the finest stripes they prefer tells you their acuity.
It gives you an equivalent acuity, yeah, based on the spatial frequency of the finest grating they consistently prefer. It's quite useful for children roughly between 1 and 3 years old.
Okay. And once they can talk a bit, maybe cooperate a little more.
Then you can move on to simple picture charts, things like the Keeler-Elliott or K-picture tests, or the E-test, where they point which way the legs of the E are facing you can make it into a game. Landolt-C works similarly.
Pointing the direction of the gap.
Right. And then there are character matching tests like Sheridan-Gardner, SICAR, or HOTV, where they have a key card and match the letter or symbol shown on the chart. Lots of options, depending on the child's developmental stage. And sometimes for uncooperative patients, or maybe if you suspect someone's feigning vision loss, you need objective measures. Optokinetic nystagmus, OKN, can be used here.
That involuntary eye movement.
Yes, that reflex. You move a striped pattern, like a rotating drum or a tape, in front of their eyes. If they can see the stripes, their eyes will reflexively follow a stripe smoothly, that's the slow phase, and then quickly flick back the quick phase to pick up the next stripe.
So if they have the reflex, they must be seeing the stripes.
Exactly. By changing the width of the stripes or the viewing distance, you can get an objective estimate of their visual acuity threshold. Now, it's quite useful. And an interesting aside, this OKN reflex can actually be absent in certain types of hemianopia caused by parietal lobe lesions.
Fascinating. Gauging acuity just by watching eye movements.
Okay, one more test related to acuity, the photostress test. What's that about? Sounds like testing light sensitivity.
It is, in a way. It specifically assesses how well the photoreceptors, the rods and cones, recover function after being exposed to a bright light. It's particularly good for uncovering subtle problems in the macula.
How's it done? Simple procedure. First, measure the patient's best near acuity. Have them read the smallest line they can on a near chart. Cover the other eye. Then shine a bright light, but from an ophthalmoscope, into the tested eye for about, say, 15 seconds.
Okay, like bleaching the photoreceptors.
Exactly. Then you remove the light and immediately time how long it takes for them to be able to read that same smallest line again. You compare the recovery time between the two eyes.
And what does the recovery time tell you?
Well, in a healthy eye, or even an eye with optic nerve disease, recovery is usually quite quick and similar in both eyes, because the photoreceptors themselves are working fine. But in macular disease, where the photoreceptors are damaged or stressed,
They take longer to recover.
much longer. Their visual pigment regeneration is delayed. So recovery takes significantly longer, usually defined as more than about 1/3 longer than their normal recovery time with a fellow eye. It's a neat way to reveal reduced photoreceptor reserve, even when standard visual acuity might still be only minimally affected, like in early central serratus retinopathy.
A very clever functional test. Okay, that's a really thorough look at assessing visual acuity and related light sense. Let's shift focus now to the area of vision, the field of vision.
Right, the field of vision, or FOV. That's simply the total area you can see while you're looking straight ahead, keeping your eye fixed. It's naturally limited by your facial features, isn't it? Your brow above, nose medially, cheek below.
So the outward field is the biggest.
Yeah, generally.
Yeah.
For a standard white test object, the normal field extends roughly 60 degrees upwards, about 60 degrees inwards towards the nose, a wider 90 degrees outwards temporally, and about 70 degrees downwards. But these values aren't fixed.
What affects them?
Things like the illumination level, the size and contrast of the test object you're using, and the adaptation state of the eye, whether it's light or dark adapted. The core concept here is what's often called the hill of vision. Retinal sensitivity isn't uniform across the field.
Right, highest in the center.
Exactly. Highest sensitivity is at the fovea, the peak of the hill, and it gradually decreases as you move out towards the periphery. Differential light sensitivity, the ability to just detect a small spot of light against a background, follows this pattern. Perimetry is essentially the process of mapping this hill of vision.
Okay, so how do you start testing the visual field in the clinic? The simplest way.
The quickest and a very useful screening test is the confrontation test. It's a bedside or basic clinical technique, really good for detecting gross defects, large blind spots, or hemianopia, where half the visual field is missing.
How does that work?
The examiner sits directly facing the patient, maybe about 60 centimeters away, head's level. The patient covers one eye, say their left, and fixates on the examiner's right eye. The examiner covers their own corresponding eye, their left. Then the examiner brings a target, like their finger or white-headed pin, in from the periphery towards the center in different meridians.
And compares when the patient sees it to when they see it.
Exactly. Assuming the examiner has a normal field, they note if the patient sees the target at roughly the same time. You test all the main quadrants. And crucially, the examiner has to watch the patient's eye constantly to make sure they maintain fixation straight ahead. It's simple, fast, and great for picking up major field losses.
But for detailed quantitative mapping, you need perimetry.
Absolutely. Perimetry encompasses the techniques used to formally examine and quantify the visual field using standardized targets and conditions. It is inherently subjective, though, because it relies on the patient saying, yes, I see it.
So patient reliability is key.
Very much so. And standardizing the test conditions is crucial. There are two main approaches: kinetic and static perimetry.
Kinetic first.
Kinetic perimetry maps the extent or boundaries of the visual field. A target stimulus of a specific size and brightness is moved from a non-seeing area in the periphery towards the center along different meridians until the patient indicates they see it.
And you plot those points?
Yes. Connecting the points where the target was first seen creates an isopter, a line representing the boundary of visibility for that specific target. You can use different sized or brighter targets to plot different isopters, mapping out the shape of the hill of vision in 2D. It also maps out any large blind spots, or scutomata. The classic instrument for this is the Goldman perimeter.
Okay, so kinetic maps the borders. How is static perimetry different?
Static perimetry measures the sensitivity of the retina at fixed, predetermined locations within the visual field. Instead of moving the target stimulus appears briefly at a specific spot, and its brightness or luminance is varied.
To find the dimmest light they can see at that spot.
Exactly. It determines the threshold sensitivity, the minimum brightness needed for detection at numerous points across the field. This gives you a more detailed quantitative map, adding a third dimension, if you like, the actual height or sensitivity level across the hill of vision.
And static perimetry, especially the automated versions, is generally preferred now for diagnosis.
Yes, it is. Automated static perimetry is considered more objective, more reproducible, and generally more sensitive to detecting subtle, early visual field defects compared to manual kinetic perimetry.
How do these automated perimeters work?
They typically use a bowl-shaped screen, like the Huncke Field Analyzer or octopus perimeter. The patient sits with their chin in a rest, covers one eye, and fixates on a central target. The computer then presents light stimuli of varying brightness at different locations within the bowl, usually in a random order to prevent the patient from anticipating where the next light will appear.
And the patient just clicks a button when they see a light.
That's right. The machine uses algorithms to determine the threshold sensitivity at each tested point. It often uses a staircase or bracketing strategy.
What does that mean?
It might start with a stimulus intensity predicted to be seen. If seen, it decreases the intensity until it's not seen. Then it increases it in smaller steps until seen again, then decreases again, bracketing the threshold. The threshold is defined as the intensity seen 50% of the time. Modern strategies like SITA, Swedish Interactive Thresholding Algorithm, are faster, using probability models to estimate the threshold more efficiently.
And the machine monitors fixation too.
Critically important, yes. It usually tracks eye movements or periodically presents stimuli in the blind spot to catch fixation losses. It can also automatically retest points that were missed initially to check for reliability.
Then it generates a printout with all this data.
Yes, a detailed printout. It shows the raw threshold values in decibels, often presented numerically, and also as a grayscale map. Darker shades mean lower sensitivity, representing pits or depressions in the hill of vision.
And those deviation plots are important, total and pattern.
Extremely important for interpretation. The total deviation plot compares the patient's sensitivity at each point to age-matched normal values. It shows, often with probability symbols, how likely it is that the measured sensitivity is abnormal, highlighting the location and depth of any defects.
Okay, so that's the overall loss compared to normal. What about pattern deviation?
The pattern deviation plot is designed to factor out any generalized reduction in sensitivity across the entire field, like you might get from a cataract dimming the view overall. It subtracts its general height reduction and then shows the remaining localized deviations from the expected pattern or shape of the hill of vision.
So it helps distinguish localized damage, like from glaucoma, from just overall dimming.
Precisely. If the total deviation plot shows significant loss, but the pattern deviation plot looks relatively normal, it suggests a diffuse depression, like cataract. But if both plots show similar defects, it points towards localized damage, like a glaucomatous nerve fiber bundle defect. That distinction is crucial for diagnosis.
Makes sense. And the printout gives summary stats, too.
Yes, visual field indices. Things like mean deviation, MD, or mean defect, which reflects the average overall deviation from normal, a measure of generalized loss. And pattern standard deviation, PSD, or loss variance, which quantifies the variability of the field loss around the expected hill shape, a measure of localized defect severity. There are also corrected versions, CPSD, CLV, that account for patient response variability.
So perimetry is obviously vital for glaucoma.
Absolutely critical. For diagnosis, staging the severity, and monitoring for progression over time. It's also essential for diagnosing and following neurological conditions affecting the visual pathways, pituitary tumors, strokes, etc. And for retinal diseases like retinitis pigmentosa or evaluating field loss after treatments like retinal laser.
Kinetic perimetry still has a role.
It does. It can be quicker for mapping the extent of large neurological defects like heminopias or quadrantinopias, and sometimes better for very peripheral field testing. And specific automated programs are used for assessing fitness to drive, checking the required horizontal field extent.
Right, the legal standards.
Okay, moving on from field testing, what about dark adaptation? Assessing night vision.
Dark adaptation testing evaluates how the eye's sensitivity increases when moving from bright light into darkness. It essentially measures the recovery of photoreceptor function, particularly the rods, which are responsible for our vision in low light or scotopic conditions.
So it plots sensitivity over time in the dark.
Yes. It measures the absolute intensity threshold, that's the minimum light level the person can detect over a period of time, usually 20-30 minutes, spent in complete darkness after an initial period of bright light adaptation. This is done using an instrument called an adaptometer.
And you mentioned rods are for scotopic vision. What are the other types?
Right. So photopic vision is cone-mediated vision, used in bright light, above about 0.03 cdme or POR, responsible for color and fine detail. Scotopic vision is rod-mediated, used in very dim light, much more sensitive, but doesn't perceive color. And mesopic vision is the intermediate range where both rods and cones contribute.
Okay. And the dark adaptation curve typically shows two distinct phases. It does, classically. There's an initial rapid decrease in threshold, meaning sensitivity increases quickly, which represents cone adaptation. This plateaus after a few minutes. Then, after maybe 5 to 10 minutes in the dark, there's a second, much steeper drop in threshold as the rods take over and become much more sensitive. This rod adaptation phase continues for about 20 minutes or more before reaching its final plateau.
So if that second phase, the rod phase, is slow or doesn't go down as far,
That indicates a problem with rod function. Prolonged or abnormal dark adaptation is a characteristic feature of diseases affecting the rods, like retinitis pigmentosa, a type of pigmentary dystrophy, or conditions like vitamin A deficiency, which is essential for rhodopsin regeneration. It can also be affected in some cases of glaucoma. It's a direct assessment of scotopic performance, which is relevant for tasks like night driving or flying.
Interesting. How about contrast sensitivity? You mentioned it earlier. How is it different from standard visual acuity?
That's a really important distinction. Standard visual acuity, like reading the Snellen chart, measures your ability to resolve fine detail under high contrast conditions, black letters on a white background. Contrast sensitivity, on the other hand, measures your ability to detect subtle differences in luminance or shading, essentially, the smallest amount of contrast you can distinguish.
So it's more about the quality of vision, not just clarity.
Exactly.
Yeah.
It reflects how well you see in real-world situations, which often involve low contrast. Thinking driving in fog, seeing facial features in dim light, reading menus in a dimly lit restaurant. You can have perfectly normal 66 acuity but still complain of poor vision because your contrast sensitivity is reduced.
How do you measure it?
There are a couple of main ways. One is using letter contrast sensitivity charts, like the Pelley-Robson or Regan charts. These charts have letters that are all the same size, but the contrast of the letters against the background gradually decreases as you read across or down the chart. You find the lowest contrast level where the patient can still read the letters, usually tested at 1 meter.
Okay. And the other way, using gratings.
Yes, using contrast sensitivity gratings. These are patterns of alternating light and dark bars, usually sinusoidal, meaning the transition from light to dark is smooth, like a sine wave. The patient might have to identify the orientation of the bars, vertical, tilted left, tilted right. The test varies both the contrast of bars and their width, or spatial frequency, measured in cycles per degree of visual angle.
So you test sensitivity across different levels of detail and contrast.
Precisely. It generates a contrast sensitivity function curve, showing sensitivity across a range of spatial frequencies. Some tests use square wave gratings, or simpler methods like the Cambridge gratings, where the patient just identifies which card has a grating versus a blank card, with decreasing contrast.
When is testing contrast sensitivity particularly indicated?
It's very valuable for patients who report significant visual difficulties, like blurry vision or trouble seeing in dim light, despite having normal or near normal standard visual acuity.
Like early cataracts.
Exactly.
Yeah.
It's often one of the first things affected by early cataracts or after certain types of refractive surgery. It's also considered a very sensitive measure of optic nerve function. Changes in contrast sensitivity can be an early warning sign or a way to monitor optic nerve diseases like optic neuritis, often seen in MS, papilledema, or even potentially glaucoma, sometimes before standard acuity drops significantly.
It really seems to capture a dimension of vision that standard VA charts miss. Okay, let's move to color vision.
Right. Testing color vision accurately for scientific investigation requires quite elaborate apparatus. But clinically, the main objectives are usually twofold. First, to determine the exact nature of any color vision defect. Is it red, green, blue, yellow? How severe is it? And second, to assess if the defect poses a potential danger, especially in occupations where color discrimination is critical, like train drivers, pilots, electricians, lookouts.
Does just asking the patient what colors they see help?
It's valuable information, yes, hearing the names they give to colors. But formal testing is necessary for diagnosis, and it's usually best to employ several different types of tests for reliability.
What are the common types of tests?
Well, there are lantern tests, like the Edridge Green Lantern. These show lights of different colors, often through apertures of varying sizes, and the patient has to name the colors. Mistakes are judged, but results can depend on the examiner's expertise and the specific lantern setup. Then there's the Farnsworth-Munsell 100 hue test. This doesn't involve naming colors, but arranging a set of colored caps in order according to hue. The number and pattern of errors give a score indicating color discrimination ability. Specific patterns of errors can be characteristic of certain conditions, like toxic optic neuropathy.
What about those plates with the dots? Ishihara plates.
Yes, isochromatic charts are probably the most commonly used screening tests. Ishihara plates are the best known. They have numbers or winding paths made of colored dots embedded in a background of differently colored dots. People with normal color vision can see the figures easily, while those with specific defects, primarily red-green deficiencies, either can't see them or see different figures.
So Ishihara is mainly for red-green.
Primarily, yes. Other similar tests, like the American Hardy-Rand-Rittler HHRR test, include plates designed to detect blue-yellow defects as well. For more precise classification, especially of red-green anomalies, you'd use an instrument called an anomaloscope.
How does that work?
The classic nasal anomaloscope presents a split field. One half is a standard yellow light from a sodium line. The patient has to match this yellow by mixing red light lithium line and green light thallium line in the other half. The specific mixture they choose and the brightness they set allows very precise diagnosis of different types of red-green deficiency, protanopia, deuteranopia, and the anomalous trichromacies. There are also anomaloscopes like the Pickford-Nicholson for testing blue-yellow vision.
So you really need a battery of tests for a full picture.
Ideally, yes. No single test is perfect or infallible. Using several different types helps confirm the defect and classify it accurately.
Okay, last functional area. Binocular vision and stereoacuity, how the two eyes work together.
Right. Binocular vision isn't just about having two eyes. It's about the brain fusing the images from both eyes into a single three-dimensional perception. Interestingly, visual acuity itself is usually a bit better with both eyes open compared to the better eye alone, often by about one line on the chart.
Why is that?
It's thought to be due to cortical summation, the brain combining the signals from both eyes. But testing binocularity goes beyond just acuity. You need to assess if the eyes are aligned properly and if the brain is truly fusing the images, or perhaps suppressing one. Tools like the Synoptophore, Baggellini striated glasses, or tests using polarized projectors can assess fusion and suppression. Binocular visual field testing can also be done.
And stereoacuity measures the 3D aspect, depth perception.
Precisely. Stereoacuity quantifies stereopsis, which is the brain's ability to perceive depth based on the slight horizontal difference or disparity between the images seen by each eye because they're separated in space.
How do you test that?
Tests for stereoacuity always involve presenting slightly different images to each eye, usually using special glasses, either red-green filters or polarized lenses. Then, specially designed pictures or patterns are viewed. Things like the Titmus fly test, with a large fly that appears grossly 3D, the TNO test, using red-green glasses and random dot patterns, or the rendered stereoacuity test, using polarized glasses with random dots and circles, are common examples. The patient has to identify which shape or symbol appears to stand out in depth.
And the results are measured in arc seconds.
Yes, seconds of arc of disparity. Normal stereoacuity is typically quite fine, around 40 to 60 seconds of arc.
What conditions cause poor stereoacuity?
Several things. Obviously, significantly impaired vision in one or both eyes, especially if acuity drops below about 618. Also, any condition that impairs binocular alignment or fusion, like strabismus, misaligned eyes, or suppression. Interestingly, stereoacuity can sometimes be disproportionately reduced compared to visual acuity in conditions that affect the timing or quality of nerve conduction, like acute optic neuritis, even if the acuity itself isn't drastically lowered.
So these functional tests really paint a detailed picture of what the patient sees and how their visual system is performing. Now let's shift gears to the physical examination, actually looking at the eye's structures, starting with the front part, the anterior segment.
Right. Examining the anterior segment, which includes everything from the front surface of the cornea back to the lens, requires a combination of techniques. You always start with just a general inspection in diffuse light.
Like with a simple pen light or the ophthalmoscope light?
It's exactly. Just get a quick overview. Look for anything obviously abnormal redness, swelling, opacities, asymmetry. Then you move to focal or oblique illumination, typically using a bright torch and often a magnifying loupe, maybe 3x or 4x. This gives you a better stereoscopic view of specific areas.
But the real workhorse, the essential instrument for examining the anterior segment in detail, is the slit lamp biomicroscope.
Oh, absolutely indispensable. You really can't do a thorough anterior segment exam without it. It cleverly combines a powerful adjustable light source that can be focused into a slit or various other beams with a binocular microscope mounted on a movable arm.
So you get magnification and controlled illumination.
Precisely. You can vary the magnification, change the angle between the illumination and viewing arms, adjust the width and height of the light beam, and focus precisely. The key thing is its versatility. It allows you to scrutinize structures in incredibly fine detail using a range of different illumination techniques. Each technique highlights different things.
Okay, walk us through those main slit lamp techniques. It sounds like a dynamic process.
It really is. You're constantly adjusting the light, the focus, the magnification, scanning across the structures. You often start with low magnification and diffuse illumination, just a broad beam of light for a general orientation. Look at the overall color, size, position of structures like the conjunctiva, iris, pupil. Tangential illumination, where the light comes in at a very oblique angle, maybe 60 degrees or more.
What does that help with?
It really enhances contrast and highlights surface texture. Great for seeing subtle elevations or irregularities on the iris surface, or the texture of a corneal lesion.
Okay, then focal illumination, using the slit beam itself.
Yes, with focal illumination, you're either directly observing the area illuminated by the focused slit beam, or sometimes viewing an adjacent area that's lit indirectly by scattered light. But the real power of focal illumination, especially with a narrow slit, is its ability to create an optical section.
Like cutting a slice of light through the tissue.
Exactly like that. You focus the narrow slit beam, say, onto the cornea. Because the corneal tissue scatters light, the path of the beam becomes visible as a bright parallel pipe shape within the cornea. Behind it, you see the optically empty dark anterior chamber. And behind that, you see the phantom of the lens, where the light beam reflects off the different layers or zones of discontinuity within the lens, the nucleus, the cortex.
And this optical section helps determine depth.
Crucially, is that corneal opacity superficial, stromal, or endothelial? Is that foreign body shallow or deep? The optical section allows you to pinpoint the depth of an abnormality with remarkable precision.
Very useful. What about retroillumination, lighting from behind?
Yes, another fundamental technique. Here, the light is directed behind the structure you want to examine. In direct retroillumination, you align the illumination in viewing beams, often sending the light through the pupil. It bounces off the retina, creating the red fundal glow, and you view the structures of the anterior segment silhouetted against that red background.
What shows up well with that?
Opacities stand out really clearly. Things like cataracts in the lens, corneal stars, even deep corneal blood vessels appear black against the bright red reflex. It's also great for highlighting breaks or holes in the iris or transparent structures like corneal cysts.
You mentioned direct retroillumination. Is there indirect?
Yes. Indirect retroillumination involves illuminating an area adjacent to the structure you're interested in, and then viewing that structure using the light reflected off the adjacent surface, typically the iris or sometimes the sclera. For example, you might shine the beam onto the iris near the limbus, but focus your microscope on the nearby cornea. Subtle, transparent things on the back of the cornea, like fine keratotic precipitates or ghost blood vessels, can often be seen best this way, illuminated by the light bouncing off the iris.
Clever. Okay, specular reflection. Sounds like looking at a mirror.
It is, essentially. It's a specific technique used primarily to visualize the corneal endothelium, that single layer of crucial cells lining the back surface of the cornea. You need to set up the illumination and viewing arms at roughly equal angles from the perpendicular, maybe around 30 degrees each. Focus a very narrow slit beam, perhaps 2 millimeters wide, precisely onto the endothelial layer.
What do you actually look for?
You look right next to the very bright reflection of the slit lamp bulb off the front surface of the cornea. What you're seeing is the reflection off the interface between the aqueous humor and the endothelial cells themselves. It appears as a golden, shimmering mosaic. You can actually see the borders of the hexagonal endothelial cells looking like dark lines against the bright background. It's the best way to assess the health and density of the endothelium and to see abnormalities like guttata in Fuchs' dystrophy. Requires very precise focus and alignment.
Sounds tricky but powerful. And the last one mentioned was scleral scatter.
Scleral scatter is another form of indirect illumination. You decenter the slit beam significantly and shine a fairly broad beam onto the temporal limbus, where the cornea meets the sclera. The light enters the cornea there and travels across within the corneal tissue via total internal reflection, eventually emerging at the nasal limbus.
Like a fiber optic pipe?
Kind of, yeah. Now, if there's any opacity or irregularity within the central cornea, it disrupts this internal light transmission and scatters the light, making the opacity visible. It's particularly good for highlighting subtle, diffuse central corneal opacities like nebulae, vortex dystrophies, or even early corneal edema that might be hard to see otherwise.
So the slit lamp isn't just one technique, it's a whole toolbox of illumination methods. Okay, let's briefly touch on examining the specific anterior segment structures applying these techniques. The conjunctiva first.
Right. You need to examine both the bulbar conjunctiva, covering the white of the eye, and the palpebral conjunctiva lining the inside of the eyelids, including the fornices, which are the cul-de-sacs where they meet. The lower lid is easy. Just gently pull it down while the patient looks up.
And the upper lid?
That requires aversion. You typically have the patient look down, place a small cotton swab or your finger gently on the upper part of the lid over the tarsal plate, grasp the eyelashes, pull the lid slightly down and forward, and then rotate it upwards and backwards over the probe or finger. That flips the lid inside out, exposing the upper palpebral conjunctiva and tarsus.
Is that usually sufficient?
For most things, yes. But if you suspect a foreign body hidden deep in the upper fornix, you might need to do a double aversion using a special retractor, like a Damar retractor. That usually requires a drop of local anesthetic, especially in adults.
And what are you looking for on the conjunctiva?
You're checking for the pattern and degree of redness, or congestion, any discharge. Foreign bodies. Signs of inflammation like papillae, which are velvety bumps, often with a central vessel, or follicles, which are smaller. Translucent bumps representing lymphoid tissue. Also looking for cysts, concretions, small yellow deposits, abnormal growths or tumors, the general health of the ocular surface, and assessing the tear film.
You mentioned distinguishing types of congestion earlier as being important.
Yes, though they often occur together, the pattern can give clues. Conjunctival congestion involves the superficial vessels. They're bright red or prominent away from the cornea, often leaving a clearer white zone right around the cornea, the limbus. It's typically associated with mucus or mucopurulent discharge, as in conjunctivitis. These vessels tend to blanch or whiten with the pressure or constrict readily with topical vasoconstrictor drops like 10% phenylephrine.
And ciliary congestion.
Ciliary congestion indicates deeper inflammation, involving the iris, ciliary body, or maybe the cornea or sclera. Here, the redness is most intense in a ring right around the circumcorneal zone. It often has a deeper, slightly purplish or lilac hue because it involves the deeper anterior ciliary vessels. It's usually associated with more significant pain, light sensitivity, photophobia, and watery tearing rather than discharge. Crucially, this type of redness does not blanch easily with pressure and is not significantly reduced by topical vasoconstrictors. Knowing the difference helps localize the problem, although often you see a mixed picture.
Okay, next structure. The sclera, the white part.
You inspect the sclera around the cornea, look for localized, raised, congested nodules. If they're relatively painless, it might be episcleritis, inflammation of the surface layer. If it's deep red or dusky congestion, often painful and may be associated with peripheral corneal changes or uveitis, it could be deep scleritis, which is more serious.
How about the scleral color?
Normally white. A distinct blue coloration, except perhaps in very young infants, is usually pathological. It suggests thinning of the sclera, allowing the darker underlying uveal tissue, choroid and ciliary body, to show through. This most often occurs in staphylomatous.
Those are bulges.
Yes, outpouchings or ectasias of the sclera, usually where it's been weakened by injury, severe inflammation like scleritis, or chronically high intraocular pressure. They can occur in different locations: anterior, near the cornea, ciliary over the ciliary body, intercalary, between cornea and ciliary body, equatorial, at the eye's equator, or posterior at the back. You also look for any discoloration or pigmentation. Slight duskiness near where the anterior ciliary vessels perforate the sclera can be normal, especially in people with darker complexions, but other pigmentation might raise suspicion of melanosis or tumor.
Got it. Now, the cornea, we touched on some aspects with the slit lamp, but let's recap key points.
Sure, the cornea should be smooth, lustrous, perfectly transparent. Surface regularity is key. Loss of substance, like an abrasion, can be very subtle. Accurate assessment often involves looking at the reflection of patterns, like the circles on a placido-keratoscopic disc, or even just the reflection of a window.
Distortions mean irregularity.
Exactly. Loss of sharpness means the surface polish is gone. Irregular distortion of the rings points to surface irregularities, like in dry eye, or structural issues like keratoconus, or significant astigmatism. Corneal topography provides a detailed computerized map of the surface shape. And newer systems like slit scanning or ORB-scan can image both anterior and posterior surfaces.
Vascularization, new blood vessels, is always abnormal in the cornea, right?
Yes, the healthy cornea is avascular. New vessels grow in response to various diseases, inflammation, infection, oxygen deprivation. Noting their position, superficial or deep, and distribution is diagnostically important. Are they localized to one area or widespread? Prognostically, especially for corneal transplantation, the degree and depth of vascularization matters a lot. Deep vessels in more than 2 quadrants significantly increase the risk of graft rejection.
How do you tell superficial from deep vessels?
Superficial vessels look like continuations of conjunctival vessels crossing over the limbus. They're usually bright red, relatively well-defined, and branch like tree limbs dichotomously or arborescently. They might even slightly elevate the overlying epithelium, making the surface uneven. Deep vessels, on the other hand, seem to arise abruptly at the limbus from deeper structures. They often look more grayish-red, less distinct, maybe giving a diffuse reddish blush. They tend to run in parallel, more radial lines within the corneal stroma, branching at more acute angles following the lamellar structure of the stroma. The overlying cornea might be hazy, but the surface itself usually remains smooth.
That's a useful distinction. What about corneal sensation?
Test it gently with a wisp of cotton wool touched to different parts of the cornea, comparing the response to the other eye. Normally, there's a brisk reflex closure of the eyelids. Diminished sensation can occur after any significant corneal disorder, but it has particular diagnostic significance in conditions like herpes simplex or herpes zoster keratitis, where you might see minimal corneal signs but grossly reduced sensation. You can quantify it more precisely with a corneal esthesiometer, which uses a fine nylon filament of variable length.
And staining the cornea.
Vital dyes are crucial for assessing the health of the corneal epithelium and highlighting subtle lesions. Fluorescein is the most commonly used. It doesn't stain healthy epithelial cells, but it brightly stains any areas where the epithelium is missing or damaged, like abrasions, erosions, or ulcers pooling in the defect and appearing brilliant yellowish green under cobalt blue light.
What about rose bengal?
Rose bengal stains dead or devitalized epithelial cells, and also mucus, a reddish pink color. It's particularly useful for highlighting conditions like superficial punctate keratitis or the dry spots in keratoconjunctivitis sicca. Alcyon blue is another stain that selectively stains mucus, useful in delineating excess mucus strands in tear deficiency states.
And finally, opacities or deposits within the cornea itself.
Right. These can range from faint haziness, nebulae, to dense white scars, leucomas. Minute investigation is needed, best done with the slit lamp's optical section and different illuminations. You look for specific lesions like the tiny epithelial or subepithelial dots of superficial punctate keratitis, and very importantly, keratic precipitates, or KPs.
We mentioned the inflammatory cells stuck on the back surface.
Exactly. They're small accumulations of inflammatory cells originating from the iris and ciliary body, the uvea, that adhere to the corneal endothelium, typically settling inferiorly due to gravity and aqueous convection currents. Their presence is a definite sign of intraocular inflammation or uveitis.
Does their appearance give clues?
Yes. Fresh KPs tend to be white, round, and somewhat dome-shaped. As they get older, they become flatter, smaller, may develop crenated edges, and often become pigmented as iris pigment gets incorporated. The type of KP is also informative. Large, greasy, waxy-looking KPs, often called mutton fat KPs, are characteristic of granulomatous types of uveitis, like sarcoidosis or TB. Smaller, fine, stellate KPs are more typical of non-granulomatous uveitis, like fuchsiclitis or sometimes herpetic uveitis.
Very important signs. Okay, moving deeper still, the anterior chamber, the space between the cornea and the iris. Assessing its depth is vital for glaucoma risk, you said.
Absolutely critical, particularly for assessing the risk of angle closure glaucoma. The depth varies. Normally, it's shallower in very young children and tends to decrease slightly with age. Average depth is around 2.5 millimeters centrally, though the cornea magnifies things, making the iris appear a bit closer.
How do you estimate the depth clinically?
The simplest way is the oblique flashlight test. Shine a penlight beam across the front of the eye from the temporal side, parallel to the plane of the iris. If the chamber is deep and the angle open, the light passes through and you'll see the nasal iris illuminated. If the chamber is shallow and the angle narrow, the bulging peripheral iris will block the light, casting a shadow on the nasal half of the iris.
Is there a more refined slit lamp method?
Yes, the Van Herrick technique. Using the slit lamp, you create a narrow optical section right at the peripheral limbus, typically with the illumination arm at about 60 degrees. You compare the apparent width of the dark space between the posterior cornea and the iris, the peripheral anterior chamber depth, to the width of the bright corneal optical section right next to it. If the chamber depth is less than or equal to about 1/4 or 14 of the corneal thickness, the angle is considered dangerously narrow and capable of closure. If it's more than half 12 the corneal thickness, closure is unlikely. It's a subjective estimation, but very useful clinically.
And for objective measurement?
You can use pachymetry attachments on some slit lamps, or more sophisticated anterior segment imaging technologies like ultrasound biomicroscopy, UBM, anterior segment OCT, ASOCT, or Scheimpflug imaging with systems like the Pentacam. These provide precise measurements of chamber depth and angle configuration.
Are there pathological variations in depth besides just shallow?
Yes. The chamber can become unevenly deep, for example, deeper peripherally than centrally in some cases of iridocyclitis, due to posterior synechia pulling the central iris back. It can become funnel-shaped, deep centrally, very shallow peripherally, in iris bombae, where the pupil is blocked, trapping aqueous behind the iris. Unequal depth across the chamber might indicate a subluxated or tilted lens. A deeper angle recess on one side could suggest ankle recession from past trauma.
Okay. What about the contents of the anterior chamber? It should just be clear aqueous humor, right?
Normally, yes, it should be optically empty. But in inflammatory conditions involving the uveal tract, iris, ciliary body, the blood vessels become leaky, allowing protein and inflammatory cells to escape into the aqueous.
And you can see this with this slit lamp.
Yes, protein leakage causes aqueous flare. It makes the normally clear aqueous slightly opalescent, so the slit lamp beam becomes visible as it passes through the chamber, like a headlight beam in fog. Flare is graded typically from 1+, barely detectable, to 4+, intense, sometimes with fibrin formation.
And cells.
You can also see individual inflammatory cells, mostly white blood cells floating in the aqueous, looking like tiny dust specks circulating the beam. Seeing cells is a definite sign of active uveitis. They're also graded, usually by counting the number of cells visible in a standard 1 mm by 1 mm slit beam field, ranging from trace, 1 to 5 cells, up to 4+, more than 50 cells, sometimes too numerous to count.
So flare and cells are key signs of active inflammation.
Absolutely. Other abnormal contents include KPs, which we discussed, adhering to the cornea. A hypopyon is a collection of inflammatory cells, MOPUs, that settles out gravitationally, forming a white layer at the bottom of the anterior chamber, typically with a flat upper level. It's seen in severe infections like endophthalmitis or infected corneal ulcers, and sometimes in sterile severe iridocyclitis. A hyphema is a collection of blood in the anterior chamber, usually after trauma, but can occur spontaneously. And in rare cases, like ocular onchocerciasis, you might even see modal microfilaria swimming in the aqueous.
Wow. Okay, onto the iris itself.
When examining the iris, you start with the basics. Its color, the clarity and texture of its pattern or stroma. Note any heterochromia, different colors between the two irids, heterochromia iridum, or different colors within the same iris, heterochromia iridus.
What are pathological signs to look for?
A dull, muddy appearance with an ill-defined pattern often suggests iris atrophy, which can result from chronic iridocyclitis. Sectoral atrophy, where only a segment of the iris is thinned and depigmented, can be a sign of previous acute angle closure, glaucoma attack, or sometimes herpes zoster ophthalmicus. Also, check for tremulousness of the iris, called iridonesis.
When does that happen?
You see it as a wobble or shimmer of the iris with rapid eye movements. It happens when the iris isn't properly supported from behind by the lens, either because the lens is absent, aphakia shrunken, or significantly subluxated, dislocated. Best seen in a dark room with oblique illumination while the patient looks quickly side to side.
What about spots or nodules on the iris?
You need to differentiate benign from pathological. Iris freckles are common, small, flat, darkly pigmented spots. Brushfield spots are small, whitish spots near the periphery, often seen in Down syndrome. Pathological nodules include Lisch nodules raised, pigmented gelatinous-appearing nodules seen in neurofibromatosis type 1, and then there are inflammatory nodules seen in uveitis. Copy nodules are small, whitish nodules found right at the pupillary margin, while Busaka nodules are larger, flatter nodules found on the iris surface, away from the pupil. Their presence suggests granulomatous uveitis.
And you also check the iris position.
Yes, examine the plane of the iris. Is it flat, bowed forward, or retracted? Pay special attention to any adhesions or synechia. Anterior synechia are adhesions between the iris and the cornea, usually in the angle. Posterior synechia are adhesions between the posterior iris surface and the anterior lens capsule, typically at the pupillary margin. Both are usually results of inflammation.
Which leads us naturally to the pupil. Its size, shape, and reactions provide a wealth of information, don't they?
They really do. They're like windows into the neurological pathways controlling the eye. Pupil size is determined by a balance between the sphincter muscle, constricts pupil, parasympathetic innervation via CN3, and the dilator muscle, dilates pupil, sympathetic innervation. Normal size varies. Pupils tend to be larger in youth and smaller in infancy and old age. They can be temporarily dilated due to myopia, fatigue, or nervous excitement, but should still react normally.
What about pathological disturbances in size?
Very important. A very large, non-reactive pupil might suggest the use of a mydriatic dilating eye drop, maybe inadvertently. Bilateral large immobile pupils could indicate profound blindness due to the severe bilateral retinal or optic nerve damage. However, it's crucial to remember that unilateral blindness never causes a fixed dilated pupil in that eye, because the consensual light reflex from the healthy eye will still cause the blind eye's pupil to constrict.
That's a key point. How do you distinguish bilateral blindness from a bilateral problem with the efferent nerve pathway causing the dilation, pupiloplegia?
You check the near reflex. In blindness, the motor pathway, CN3, is usually intact, so the pupil should still constrict when the patient attempts to accommodate and converge on a near object. Also, importantly, having normal light reflexes does not rule out blindness caused by lesions above the lateral geniculate body in the brain, for example, lateral occipital lobe strokes, uremia, because the reflex pathway bypasses the visual cortex. Dense cataracts or vitreous hemorrhage also shouldn't abolish the pupillary light reflex if you use a bright enough light.
Okay. What if the dilated pupil is also associated with paralysis of accommodation?
Dilated, immobile pupils plus paralysis of the ciliary muscle, inability to focus up close, strongly points towards a third nerve palsy, affecting both pupillary and ciliary branches, termed ophthalmoplegia in turn if isolated, or part of a complete third nerve palsy. This can result from various causes: lesions affecting the third nerve nucleus or pathway, meningitis, encephalitis, diphtheria, lead poisoning, orbital disease, trauma.
What about unilateral dilation from sympathetic issues?
Irritation of the cervical sympathetic nerves can initially cause pupil dilation on that side. This might happen with things like swollen neck lymph nodes, apical lung problems, pneumonia, pleurisy, a cervical rib, or a thoracic aneurysm compressing the chain. Also, certain spinal cord conditions like syringomyelia or meningitis affecting the lower cervical upper thoracic cord. However, sympathetic irritation often eventually progresses to sympathetic paralysis.
Which causes constriction, like in Horner syndrome.
Exactly. Horner syndrome is caused by interruption of the sympathetic pathway anywhere along its course, from the brainstem down into the chest and back up to the eye. The classic signs are a miosis, a smaller pupil on the affected side, eprosis, a mild drooping of the upper eyelid due to paralysis of Muller's muscle, and often anhidrosis, lack of sweating on that side of the face. Some also describe a slight anophthalmos, eye appearing sunken.
Okay, so that covers dilated pupils. What about abnormally small pupils, miosis?
Small immobile pupils might suggest the use of miotic eye drops, like pilocarpine for glaucoma, or systemic opioids like morphine. Small, sluggish pupils, especially if the iris looks muddy, are typical of active iritis. Small, immobile pupils that don't dilate well, even with a strong mydriatic drop, suggest posterior synechiae from previous uveitis, essentially sticking the pupil margin down.
What about bilateral small pupils?
Could indicate irritation of both third nerves centrally, or maybe bilateral palsy of the sympathetic system, as seen in pontine hemorrhage. And in acute angle closure glaucoma, the pupil is usually mid-dilated or large, often vertically oval, and immobile, not small.
Let's go really deep on examining the pupillary reflexes, as they're so diagnostically crucial.
Absolutely. Always test reflexes before instilling any dilating drops. You need careful, detailed observation. Best done in low background illumination, with the patient looking at a distant target to avoid triggering the near reflex. Use a bright, focused light source.
What are the key reflexes to test?
3 main ones. 1, the direct reaction to light, constriction of the pupil in the eye you shine the light into. 2, the consensual reaction to light, constriction of the opposite pupil when you shine light into the first eye. 3, the reaction to accommodation and convergence, constriction when shifting focus from a distant to a near target.
How do you elicit the direct reaction properly?
You can cover both eyes, then remove the cover from one eye while shining the light into it and observe the speed and maintenance of constriction in that eye. Repeat for the other eye.
And the consensual.
Shine the light in one eye, but this time observe the pupil of the other eye. It should constrict simultaneously. Repeat, shining light in the second eye and watching the first.
What if it's hard to see the reaction, maybe in bright ambient light or with very small pupils?
Good point. If the room isn't dim enough or the reaction is subtle, move to a darker setting. Use focal illumination, like shining the ophthalmoscope beam directly onto the macula, which is the most sensitive area for triggering the reflex, and then quickly move the beam on and off the pupil to see movement. The slit lamp is excellent for this focus. Focus the beam right on the pupillary margin and flash the light into the aperture. If there's absolutely no movement, the reaction is absent.
What about the hemiopic pupillary reaction, Wernicke's sign?
That's rarely demonstrable unequivocally, mainly because it's hard to stimulate only half the retina without light scattering. It's associated with lesions of the optic tract after the chiasm, but before the pupillary fibers branch off. The idea is that light shown on the non-seeing half of the retina, for example, the nasal half in a temporal hemianopia, should elicit less pupillary constriction than light shown on the seeing half. Best attempted with a very fine slit lamp beam, but often ambiguous in practice.
The swinging flashlight test is much more clinically reliable for afferent pathway issues, isn't it?
It's absolutely fundamental. It's the best test for detecting a relative afferent pupillary defect, RAPD, also known as a Marcus gun pupil. This indicates that the afferent signal, the signal coming from the retinoptic nerve, is weaker on one side compared to the other.
How do you perform it?
You swing a bright light source rhythmically back and forth between the two pupils, holding it on each eye for about 2-3 seconds, before swinging across the nose to the other eye. You repeat this several times, carefully observing the pupil that the light is currently shining on.
What are you looking for? What's normal versus abnormal?
Normally, when you swing the light from eye A to eye B, pupil B should either remain constricted, because the consensual input it was getting from eye A is equal to the direct input it's now getting, or possibly constrict slightly further. In an RAPD affecting eye B, the afferent signal from eye B is weaker. So when you swing the light from the healthy eye A to the diseased eye B, the overall level of pupillary stimulation actually decreases, causing both pupils to paradoxically dilate or escape slightly, even though eye B is now receiving direct light.
So the dilation of the pupil you just swung the light to is the key sign.
Exactly. That dilation or escape upon illumination of the affected eye is the Marcus gun pupil RAPD. Swinging the light back to the healthy eye will then cause both pupils to constrict again, because the signal strength increases. It's often the earliest objective sign of optic nerve disease, like optic neuritis, even before vision drops significantly.
Very sensitive test. And testing the near reflex.
Have the patient look at a distant object, then quickly shift their gaze to a near target, like your finger held about 15 centimeters away. Tell them to focus on the near target. As their eyes converge, you should observe the pupils constricting.
Okay. Now, what about conditions where these reflexes are abnormal or dissociated?
Yes, these are diagnostically very important. Loss of all pupillary reflexes, light and near, in a blind eye points to a lesion in the retina or optic nerve before the chiasm. The hemiopic reaction, if detectable, points to an optic tract lesion. A lesion in the third nerve efferent pathway will abolish both light and near reflexes on that side.
But some lesions affect the pathways in the midbrain more selectively.
Exactly. This leads to the classic dissociations. The Argyle-Robertson pupil is the prime example, typically caused by neurosyphilis affecting the tectal region of the midbrain. Here, the pupils are usually small, meiosis, irregular, and characteristically show no reaction to light, neither direct nor consensual, but they do constrict normally, often quite briskly, during accommodation convergence for near vision. This is termed light-near dissociation. They also typically fail to dilate well with mydriatic drops.
So absent light reflex, present near reflex. What about the atonic pupil?
Atonic pupil is another cause of light-near dissociation, but it's different. It's usually idiopathic, unknown cause, not related to syphilis, often occurs in young women, is frequently unilateral, and can be associated with absent knee or ankle jerks, Holmes-80 syndrome.
How does it differ visually from Argyle-Robertson?
The AD pupil is typically slightly dilated or larger than its fellow, whereas AR pupils are small. The light reaction isn't completely absent, but is extremely sluggish and tonic. There might be very slow, segmental, vermiform, worm-like constriction after prolonged light exposure. The near reaction is also abnormal. It's present, but again, very slow and tonic. It takes a long time to constrict, and then stays constricted, fails to retillate quickly, long after the patient looks away from the near target.
So AR is small, no light, brisk near. AD is larger, very portonic light, slow tonic near.
That's a good summary. Another key differentiator is the pharmacological test. The atonic pupil shows denervation hypersensitivity and constricts markedly to a very dilute 0.1% or 0.125% pilocarpine solution, which wouldn't affect a normal or Argyle-Robertson pupil. Patients with AD's pupil often complain of blurred near vision initially due to associated tonicity of the ciliary muscle affecting accommodation.
Fascinating how much the pupils can tell you. Okay, let's move into the eye's interior now, starting with the lens.
Right. Thorough examination of the lens really requires both the slit lamp and the ophthalmoscope. Obvious opacities in the pupillary area might be visible just by simple inspection or with focal illumination.
What does the lens look like normally on the slit lamp?
In a young person, the lens substance is almost perfectly clear, maybe just a faint bluish haze. With age, the lens nucleus naturally becomes denser and slightly yellowish, nuclear sclerosis. This can make the lens look somewhat hazy or milky on direct slit lamp view, but it might not yet be a visually significant cataract. If you look with the ophthalmoscope using retroillumination, distant direct, the red reflex might still be perfectly clear.
Why does it look milky then?
It's due to increased light scattering from the denser nucleus, not necessarily true opacity blocking light. The milkiness is the light reflected back towards you from within the lens substance itself.
So how do actual cataracts' true opacities appear?
With direct or oblique illumination on the slit lamp. They typically appear as gray, white, or sometimes brownish yellow areas within the lens. But the key view for confirming and localizing them is using retroillumination, either with the slit lamp against the red fundal glow, or with distant direct ophthalmoscopy looking at the red reflex for about 20 centimeters away. Against the red reflex, any significant opacity will appear black because it's blocking the light returning from the fundus.
And different types of cataract have characteristic appearances and locations.
Yes. The form and distribution help diagnose the type. For example, a small white spot right in the center of the pupil might be an anterior polar cataract on the front capsule, or maybe old pupillary exedage stuck to the lens. Spoke-like, triangular opacities starting from the periphery and pointing inwards are typical of cortical cuneiform senile cataracts. A completely white appearance filling the whole pupil usually indicates a total or mature cataract. A yellowish-white appearance with maybe white spots of calcification, especially if the iris is tremulous, iridodenesis, might suggest a shrunken, hypermature, Morganian, or calcareous lens. You also need to differentiate lens opacities from things like inflammatory membranes across the pupil formed by uveal exudates.
Okay. And behind the lens is the posterior chamber.
Yes, that small space between the back surface of the iris and the front surface of the lens. It's normally filled with aqueous humor that flows forward through the pupil. Because the iris is opaque, you can't really visualize the posterior chamber directly.
Right. So that covers the anterior segment structures in detail. Now, before we get to the fundus itself, we need to talk about measuring the pressure inside the eye, tonometry.
Absolutely essential. Tonometry, the assessment of intraocular pressure, IOP, is a cornerstone of glaucoma diagnosis and management. It's vital for detecting high pressure and for monitoring the effectiveness of anti-glaucoma medications.
Is there a way to estimate it without instruments?
There's the very rough subjective method of digital palpation. You have the patient look down and gently palpate the firmness of the globe through the closed upper eyelid, usually using 2 index fingers alternating pressure, like testing for fluctuation elsewhere in the body. You compare the feel between the 2 eyes.
But that's not very accurate, I imagine.
Not at all. It's purely qualitative and highly unreliable, only useful for detecting very gross differences in pressure, perhaps. Accurate measurement requires instruments called tonometers.
What's the classic type? The Sheets tonometer.
Yes, the Sheets tonometer is an indentation tonometer. It works by measuring the depth to which a small weighted plunger, or stylet, indents the center of the anesthetized cornea when the instrument rests vertically on the eye. A lever connected to the plunger magnifies this movement and indicates a reading on a scale.
How does indentation relate to pressure?
The depth of indentation depends on both the IOP pushing back against the plunger and the distensibility or rigidity of the eye wall, cornea and sclera. Higher pressure or stiffer eye results in less indentation. You use different weights, 5.5, 7.5, 10, 15 grams, to try and get a reading in the most accurate range of the scale, usually 2 to 4 millimeter deflection. The scale reading is then converted to an IOP estimate in MEMHG using a calibration chart provided with the instrument.
You mentioned rigidity affects it. Is that a problem?
Yes, that's its main limitation. Individual variations in corneoscleral rigidity can significantly affect the accuracy. A very stiff eye might give a falsely high reading, while a very distensible eye, like in high myopia, might give a falsely low reading. So, Sheets tonometry is often inaccurate for absolute values, but can be useful for approximate readings or for comparing readings between the 2 eyes, or tracking changes in the same eye over time, provided rigidity isn't changing. You always note the reading and the weight used, e.g. 20.6 millimil Hg, Sheets 45.5 G. It's also less reliable on steep, thick, or irregular corneas or after certain surgeries.
So what's considered the more accurate method? Applanation tonometry.
Yes, applanation thermometry is generally considered more accurate and is the clinical gold standard. It's based on the Imbert-Fick principle. This principle states that for an ideal thin-walled sphere, the internal pressure, P, is equal to the external force required to flatten or applanate a specific area A of its surface divided by that area, P equal Fa.
How does that avoid the rigidity problem?
The genius of applanation tonometry, particularly the Goldman design, is that it flattens a very specific area of the cornea, 3.06 millimeter diameter. At this particular diameter, the inward force due to the surface tension of the tear film meniscus formed around the tonometer tip almost exactly cancels out the outward force needed to bend the cornea, the corneal rigidity factor. So the measurement becomes largely independent of individual variations in ocular rigidity. Also, it displaces a tiny volume of aqueous, only about 0.05 millil, so it barely alters the eye's actual pressure during measurement.
And the Goldman applanation tonometer is the most common version, usually on the slit lamp.
It is. It uses a small, flat-surface plastic prism tip, a biprism, attached to a force-measuring device on the slit lamp. This tip is brought into contact with the center of the anesthetized cornea, which has been stained with fluorescein dye.
What do you see through the slit lamp?
You look through the prism tip with a cobalt blue filter on the slit lamp. The fluorescein tear film meniscus around the flattened area is optically split by the prisms into 2 green semicircles, or Myers. You then turn a calibrated dial on the tonometer, which applies a measurable forward force to the prism tip.
Until the Myers align.
Exactly. You increase the force until the inner edges of the 2 green semicircles just touch and perfectly align, forming a complete circle or an S shape, depending on the prism type. At that point, the flattened area is exactly 3.06 millimeter. The reading on the dial, multiplied by 10, directly gives the IOP in mmHg, because a force of 0.1 gram corresponds to 1 millimeter street pressure at this diameter.
Does the appearance of the Myers matter?
Yes, very much. If you have too much fluorescein, the green semicircles will be too thick, and you'll tend to underestimate the IOP. If you have too little fluorescein, the Myers will be too thin, and you'll overestimate the IOP. You want nice, crisp semicircles of medium thickness. Also, significant corneal astigmatism can distort the Myers into ovals, requiring you to average readings taken at different orientations or align the prism mark with the axis of the minus cylinder. And obviously, it can't be used accurately on scarred or very irregular corneas.
Are there portable applanation tonometers?
Yes. The Perkin tonometer is a handheld version using the Goldman principle, useful for patients who can't sit at the slit lamp. Other electronic handheld devices like the Tonopin use a similar applanation principle, but with a smaller tip and provide a digital readout, often averaging several readings.
What about the air puff tonometer, non-contact tonometry?
Yes, non-contact tonometers, NCT, also work on the principle of applanation. They direct a calibrated puff of air onto the cornea. A sensor detects the precise moment when the air puff has flattened the predetermined area of the cornea by measuring reflected light. The time it takes to achieve this flattening is related to the IOP. Higher pressure requires a stronger or longer puff, or less time for a standard puff, to achieve flattening. They're useful for screening as they don't require anesthesia or fluorescein, but are generally considered slightly less accurate than Goldmann ablation, especially at higher pressures or with corneal abnormalities.
Okay. And the average normal IOP measured by applanation is roughly?
Approximately 15 to 17 millimilli HD is considered the average, but there's a range usually cited as about 10 to 21 millimilli HD.
Got it. One more anterior segment technique. Gonioscopy? What's its purpose?
Gonioscopy is the technique used to visualize the structures in the angle of the anterior chamber. That's the junction where the peripheral cornea meets the root of the iris. This area is crucial because it contains the trabecular meshwork and the canal of Schlemm, the main drainage pathway for the aqueous humor out of the eye.
Why can't you just see it directly with the slit lamp?
Because of the optics of the cornea. Light coming from the angle structures strikes the inner surface of the cornea-air interface at too oblique an angle and undergoes total internal reflection back into the eye. So you can't see into the angle directly from the outside. It's hidden by the opaque scleral shelf externally and by total internal reflection optically.
So you need a special lens to overcome that.
Exactly. You need a gonioscopy lens or gonioscope, which is essentially a special contact lens placed on the anesthetized cornea used in conjunction with the slit lamp. There are two main types, indirect and direct.
Indirect first, like the Goldmann lens.
Yes, the Goldmann type is the classic indirect gonioscope. It's a contact lens with one or more mirrors built into its sides, angled typically around 62 or 64 degrees. These mirrors reflect the light coming from the angle structure sideways, out through the front of the gonioscope lens, allowing the examiner using the slit lamp to view an image of the angle. They can have 1, 2, or commonly 4 mirrors. A 4-mirror lens allows you to examine the entire 360 degrees of the angle just by rotating the slit lamp beam, without having to rotate the lens itself on the eye.
You mentioned indentation gonioscopy earlier.
Right. Some 4-mirror gonioscopes, particularly those with a smaller diameter base, around 7 millimeter, allow for indentation gonioscopy. By gently pressing the lens against the central cornea, you displace aqueous fluid into the peripheral angle, which can push the peripheral iris posteriorly and help to artificially open up a narrow angle, allowing you to visualize the structures more clearly or determine if the angle closure is due to iris apposition versus permanent adhesions, synechia. It's a very important dynamic technique for evaluating narrow angles.
Okay. And direct gonioscopes.
Direct gonioscopes, like the Cuppy lens, are typically larger, dome-shaped contact lenses filled with saline or viscous fluid. They work by eliminating the cornea-air interface and refracting the light rays from the angle directly out towards the observer, providing a panoramic upright view of the entire angle simultaneously. They are often used with a handheld microscope, especially for examining infants or children under general anesthesia while they are lying supine.
What are the key landmarks you're looking for in the angle?
Start from the corneal side and moving posteriorly towards the iris root in a typically open angle you should identify. Schwalbe's line, a glistening white line marking the peripheral termination of Decimet's membrane of the cornea, then the trabecular meshwork, a slightly pigmented grayish band overlying the canal of Schlemm, then the scleral spur, a dense white line which is the anterior projection of the sclera, and finally the ciliary body band, a darker gray or brownish band which is the anterior surface of the ciliary body from which the iris arises.
And identifying these helps determine if the angle is open or narrow.
Precisely. You need to see how many of these structures are visible. Schwalbe's line is often identified by finding where the anterior and posterior corneal slit beams meet in an octical section. The trabecular meshwork is the critical drainage structure. If you can only see Schwalbe's line, or maybe just the anterior trabecular meshwork because the iris is bowed forward, the angle is considered narrow or closed. The slit beam itself can be used to evaluate the angle width between the posterior cornea and the peripheral iris.
Okay. Last technique listed for the anterior segment is transillumination.
Transillumination is a relatively simple technique used mainly to help differentiate solid masses, like tumors, from fluid-filled cysts, or to locate opaque foreign bodies within the eye.
How does it work?
You use a very bright focused light source, often a special transilluminator instrument, pressed against the outside of the eye, conjunctiva or sclera, in a dark room. You observe the pupil. Normally the light passes through the eye tissues, reflects off the fundus, and the pupil glows red. If there's a solid opaque mass, like a melanoma, in the path of the light, it will block the light and that corresponding area of the pupil will appear black instead of red. A cyst filled with clear fluid, however, would usually still transilluminate red.
Can you use it for the whole eye?
It's most effective for the anterior half of the eye, where you can place the light source directly over the area of interest. Detecting posterior segment masses this way is harder. Sometimes it's done intraoperatively after opening Tennant's capsule, or less reliably using indirect methods like shining a powerful light in the patient's mouth.
Right. Okay, wow, that is a truly comprehensive journey through assessing visual function and examining the anterior segment. It really highlights the level of detail involved.
It does. We've covered the essential functional tests. Visual acuity using various charts and methods like Snellen and log-MR, handling special cases, objective tests like OKN, and functional tests like photostress. Then the visual field, from basic confrontation to the intricacies of kinetic and automated static perimetry, and interpreting those complex printouts, plus dark adaptation, contrast sensitivity, color vision, binocular function, and stereo acuity. Each measures a different facet of vision.
And then the structural examination of the anterior segment, starting with general inspection, but really emphasizing the power and versatility of the slit lamp biomicroscope, using diffuse light, focal optical sections, retroillumination, specular reflection, scleral scatter.
Exactly. Applying those techniques systematically to examine the conjunctiva, sclera, cornea, looking for things like vascularization, sensation changes, staining patterns, opacities, and those critical KPs. Then assessing the anterior chamber depth and contents flare and cells being key signs of inflammation. Evaluating the iris for atrophy, nodules, synechia, and the detailed examination of the pupil, its size, shape, and those incredibly informative reflexes, including the RAPD and the classic dissociated pupils like Argyll-Robertson and 80s. Finally, checking the lens for clarity and cataracts.
Plus, the crucial measurements of tonometry for IOP and gonioscopy for visualizing the drainage angle, both absolutely vital for glaucoma management.
It really underscores that a thorough eye exam isn't just one test, but a synthesis of information gathered through many different techniques, each providing a unique piece of the puzzle.
Absolutely. And now we need to delve into the methods for examining the posterior segment, the vitreous, retina, and optic nerve, which requires a whole different set of optical principles and instruments. Ophthalmoscopy.
That's right. Seeing the back of the eye clearly requires overcoming the eye's own optics and getting illumination in and the view out effectively. That's what ophthalmoscopy is all about.
So let's dive into that next. The history is interesting of von Helmholtz figuring out how to see in.
Indeed. From his simple plane mirror to Reut's concave mirror, and eventually incorporating internal illumination and lens batteries, the basic principle evolved to what we use today. Modern ophthalmoscopes are sophisticated, but the goal is the same. Illuminate the fundus and allow the examiner to see the reflected image.
You mentioned a routine sequence earlier. Start distant, move closer.
Yes, a systematic approach is best. Start with a preliminary check at about 1 meter, maybe just with the mirror or ophthalmoscope set to 0. Look for the red reflexes at present, uniform, any black spots. Tilting the mirror can give a rough idea of refractive error. Then move closer to about 20-22 centimeter distant direct ophthalmoscopy. Here you can see the cornea and iris magnified, confirm external findings, and spot gross media opacities or something obvious just behind the lens, like a large detachment.
Then you move in for the closer views.
Right. Next is usually direct ophthalmoscopy for a magnified view of the posterior pole. Then, for even more detail and wider views, especially peripherally, you use indirect ophthalmoscopy. And slit lamp biomicroscopy with special lenses offers the highest magnification stereoscopic views of the central fundus. Dilating the pupil with mydriatic drops makes all of these posterior segment views significantly easier and more complete.
Okay, let's break down those main fundus viewing methods. Indirect ophthalmoscopy first, the headset one.
Yes, binocular indirect ophthalmoscopy, BIO. The examiner wears a headset with a light source and binocular viewing optics and holds a strong convex condensing lens like plus 14D, plus 20D, plus 28D in front of the patient's eye.
What are the major advantages of BIO?
Several key ones. It gives a much wider field of view compared to direct ophthalmoscopy. The illumination is very bright, which helps penetrate media opacities like cataracts or vitreous hemorrhage. You get excellent stereopsis, true depth perception. And it's the best way to examine the peripheral retina out to the ora serrata, especially when combined with scleral depression, gently indenting the eye wall from the outside. It works well regardless of the patient's refractive error.
What's the main challenge?
The image is inverted, both vertically and laterally. You see everything upside down and backwards, so you have to mentally reorient everything, especially if you're drawing the findings or planning surgery based on the view. The stronger the lens you use, pure AG plus 28, The wider the field, but the lower the magnification and stereopsis. A weaker lens, plus 14D, gives higher magnification but a narrower field.
How does it actually work optically?
The strong convex lens held near the patient's eye effectively makes the eye highly myopic. It converges the light rays emerging from the patient's fundus to form a real inverted image located in the air between the condensing lens and the examiner's headset. The headset optics then focus on this aerial image.
So you have to hold the lens at the right distance.
Yes, you hold the lens, usually curved surface towards you, parallel to the patient's iris plane. You adjust your working distance and the lens position until the aerial image of the retina comes into sharp focus. You often have to tilt the lens slightly to move annoying reflections from the lens surfaces out of your line of sight, but not too much or it causes distortion.
Okay, now direct ophthalmoscopy, the handheld one.
Right, the standard, portable, self-illuminated ophthalmoscope. It provides a highly magnified view, about 15 times magnification in an emmetropic eye, but of a much smaller area of the fundus, typically just the posterior pole, optic disc, macula, major vessels.
And the image is upright.
Yes, the image seen is virtual and erect, upright. It uses the patient's own cornea and lens, plus lenses in the ophthalmoscope dialed in by the examiner, to focus on the retina. The examiner needs to correct for both their own and the patient's refractive error using the lens wheel.
You mentioned it's good for measuring level differences.
Yes, that's a unique advantage. By noting the difference in lens power needed to focus on different structures, you can estimate their relative elevation. For example, if the bottom of a cupped optic disc requires a naked 3D lens to be clear, and the rim of the disc requires 0D, that's a 3 diopter difference. If the top of a swollen optic disc requires plus 2D and the surrounding retina requires 0D, that's a 2 diopter difference. A difference of 3 diopters roughly corresponds to a 1 millimeter difference in depth or elevation at the fundus. Very useful for assessing disc cupping, swelling, or retinal lesions.
How do you use it routinely?
You typically start with the lens wheel set around plus 10D or plus 20D from a short distance. Find the red reflex, then move closer to the patient's eye while gradually decreasing the plus power, or increasing minus power if needed, until the retinal details come into focus. This allows you to visualize structures from the cornea back through the lens and vitreous to the retina. Opacities in the media will appear black against the red reflex if dense, or may look reddish or whitish depending on how much light they reflect versus transmit.
So direct gives high magnification of the central area. Indirect gives a wide stereoscopic inverted view, especially of the periphery. What about using the slit lamp to view the fundus?
Yes, slit lamp biomicroscopy of the fundus using special lenses provides yet another valuable perspective. The slit lamp's own optics normally focus in the anterior part of the eye. To see the posterior structures, you need an additional lens to counteract the eye's refractive power and allow the slit lamp microscope to focus on the retina or vitreous.
What kinds of lenses are used?
Two main types. High-power non-contact convex lenses, or contact lenses placed directly on the eye. Common non-contact lenses are double aspheric lenses like plus 60D, plus 78D, or plus 90D. These are held by hand just in front of the patient's eye. They produce a real, inverted, magnified aerial image of the fundus between the lens and the slit lamp, similar to indirect ophthalmoscopy, but viewed with the slit lamp's variable magnification and illumination controls.
What's the advantage of this method?
It provides a very high-quality, highly magnified stereoscopic view of the central posterior pole, the optic disc, macula, vessels, excellent for examining fine details binocularly. You can use the slit beam to create optical sections through retinal lesions, assess edema, differentiate macular cysts from holes with great clarity. The plus 60D lens gives higher magnification, good for detailed disc or macula views, while the plus 78D or plus 90D give a wider field.
Is it hard to do?
It takes some practice. You hold the lens steady near the eye, maybe resting your hand on the forehead bar. Align the slit lamp illumination and observation arms coaxially. Start with low magnification. Find the fundal glow, then pull the slit lamp back slightly while adjusting the lens position until the aerial image is focused. Tilting the lens slightly helps manage reflections.
What about contact lenses for fundus viewing with the slit lamp?
These lenses sit directly on the anesthetized cornea using a coupling fluid. Some, like the Ruby lens, which is actually a highly concave NECA 55D lens, not convex, or the central part of a Goldman lens, essentially neutralize the corneal power and allow direct viewing of the posterior pole. The image formed is virtual and erect, located within the anterior vitreous. The Ruby lens gives low magnification and a small field. Other contact lenses, like the Goldman 3-mirror lens, are designed for indirect viewing of the peripheral retina. The central portion gives a direct view of the posterior pole. Then it has 3 mirrors angled differently. For example, 59 degrees, 67 degrees, 73 degrees, that reflect images from progressively more peripheral parts of the fundus, equator or serrata, into the slit lamp microscope. You rotate the lens to view the entire periphery through the different mirrors. There are also wide-field contact lenses like the panfrontoscopic lens.
So combining direct ophthalmoscopy, indirect ophthalmoscopy, and slit lamp funduscopy with various lenses gives you a complete toolkit for visualizing the entire posterior segment.
Exactly. Each method offers a different trade-off between magnification, field of view, stereopsis, image orientation, erect inverted real virtual, and ease of use through media opacities. Using them appropriately allows for a truly comprehensive examination of the vitreous, retina, choroid, and optic nerve head.
That is an incredibly detailed overview of the entire clinical eye examination process. We've really journeyed from the front surface right to the back, covering both function and structure.
We have. We systematically covered the assessment of visual function VA with Snellen, log MAR, and specialized tests, field of vision with confrontation and various perimetry techniques, dark adaptation, contrast sensitivity, color perception, and monocular vision, including stereoacuity. We emphasize the importance of standard tests, but also objective measures like VEP or OKN and binocular assessments.
And then the meticulous examination of the anterior segment, starting with general inspection and the adnexa, but really highlighting the indispensable role of the slit lamp. Using all those techniques, diffuse, focal, retroillumination, specular reflection, scleral scatter to scrutinize the conjunctiva, sclera, cornea, anterior chamber, iris, pupil, lens, and even the posterior chamber indirectly, mentioning modern imaging like ASOCT too.
Absolutely. And not forgetting tonometry to measure IOP using indentation, or more commonly now, applanation methods, and gonioscopy to directly visualize the critical drainage angle. Then we move to the posterior segment, explaining the principles and techniques of ophthalmoscopy, direct for magnified central views, indirect for wide-field stereoscopic views, and slit lamp biomicroscopy with condensing lenses for highly magnified, detailed stereoscopic assessment of the posterior pole and periphery. Noting the different image characteristics of each method is key.
It's clear that truly mastering this field requires not just knowing how to perform these tests, but deeply understanding the principles behind them, what specific findings mean, and how to integrate all that information. It's about seeing the whole picture behind the individual numbers and images.
Precisely. It's pattern recognition built on a solid foundation of knowledge and practical skill across this wide array of techniques.
Thinking about the sheer variety of these methods, from something as basic as counting fingers or comparing field loss to your own, all the way to using laser interferometry, automated threshold perimetry, or high magnification slit lamp techniques, what does the necessity for this diverse toolkit tell us about the eye itself?
It tells us just how incredibly complex the eye and the visual system are. There isn't one single way to assess everything. You need different approaches to measure clarity, field extent, light sensitivity, color perception, 3D vision, structural integrity from the front surface to the retina, pressure dynamics, drainage pathways.
It really highlights the dedication required for clinicians to truly master its examination, doesn't it? To become proficient in all these techniques and, more importantly, in synthesizing the findings. What does achieving that mastery, combining this art and science, ultimately allow us to understand about vision and eye health?
I think it allows us to appreciate the eye not just as an optical instrument, but as a dynamic, living system where structure and function are inextricably linked. Mastery means being able to pinpoint disruptions in that system, often very early, and understand their implications for the patient's overall visual well-being. It's about connecting all the dots provided by these diverse examination techniques to build that complete, actionable picture.